All right, good afternoon, everybody. Thank you for joining us here. I know it was a competitive block, and so we're thrilled that you chose us instead of all the other sessions. I'm Niyum Gandhi. I'm the CFO at Mass General Brigham. Delighted to be joined here by Fritz François, who's the Chief of Hospital Operations at NYU, Susan Huang, who's the CEO of the Providence Clinical Network, and Ron Wall's the Chief Operating Officer at Mass General Brigham. And we're going to talk, I'm going to give them a chance to share more about their organizations, actually, as we tee up some of the first questions. We're going to talk about this idea of kind of care delivery transformation, especially in a resource-limited era. And the reason that resource-limited era thing, I think, is important for those of you who work in health services or in healthcare delivery. You're experiencing this. For those of you who are maybe on the investing or life sciences or med device side, you may not be living it day to day, but it's been a challenging 5 years or so for care delivery coming out of the pandemic, and then having the inflationary crisis, which has been really challenging for hospitals and health systems and physician groups, along with the labor market dynamics. We're all heavy users of clinical labor in our organizations. People come to our organizations to see the people, not to see the buildings, and managing workforce challenges has been top of everybody's mind. And it's not necessarily going to get any easier as we think about the macroeconomic forecast looking forward. But on the flip side, as we were doing some of our prep calls, I was really struck by the opportunities that organizations have, that healthcare delivery organizations have, to really use this as a catalyzing time to transform. With what's going on demographically, as we have an aging population, with what's happening therapeutically, which you've been seeing in some of the other sessions around here, and then also with what's happening with technology. But a lot of it is decidedly low tech, and so you'll also hear how some of these organizations are dealing with workforce challenges, culture challenges, and just overall transformation in an industry that is often relatively slow to take step function transformation. So with that, Fritz, maybe I'll start with you. You guys have been on a really impressive transformation journey, going back a decade with what you've done around high reliability organization and other kind of transformative initiatives. Could you walk us through a little bit kind of what led to the case for change for the transformation that you've been driving, what the focus is, what you all have learned?
Sure, it's a great question, Niyum, and thank you again for this invitation. Glad to be with everyone. And it's easy to look back and say that this was completely intentional for us, but the reality is there were some stressors that forced us to think about how we were going to transform. And I'm going to share with you sort of the framework of why that happened or how it happened. But there are three categories that I'll touch on. And the first is financial. And the financial pressures that we faced was that we had gone through a merger with a different organization. It was actually with Mount Sinai in New York, and went through a demerger. And when the demerger occurred, we had a lot of debt. So without a lot of resources, the question is, how are we going to prioritize? What is it that we're going to do as an organization? What are the issues that we are facing and now to move forward? There was one thing that, even though we didn't have a lot of resources, that we thought if we had to invest, we need to invest in this thing, which we thought actually was going to be very, very important for it. Well, what was it? It was the electronic health record, that we wanted one that allowed us to align not only what the information on the inpatient side, but also on the ambulatory side, including billing, registration, et cetera. It had to be one system with very little interfaces in terms of other third-party systems, et cetera. It was costly, but we thought that that was important in terms of the investment. The second was cultural. And the cultural element here that we were faced with was to think about, are we going to focus, and our focus up to that point was certainly in terms of inpatient care. But as we thought about moving forward in terms of care delivery, will that be our focus in terms of hospitals, or should it be the ambulatory network? And we chose the latter, not the former. So again, first of all, the financial piece, which was a stress for us. I mean, we invested in the EHR. Then we focused on the ambulatory network. The third aspect was more structural. And what I mean by structural was that, okay, so now we've invested in the EHR, Now we're going to focus on the ambulatory network. It is a cultural change because to that point, all our strategies and our focus was on what happens on the inpatient side. We were very, very small, actually, in terms of the ambulatory network. So then we get to this notion of then structurally, where are we going? And if we're going to grow as a system, now we have to consider that if we're going to add another hospital, it's all in. So again, we had a fundamental question to ask, how do we want to structure this? And we decided that we would have one provider number. Just think about that for a second. One provider number, one playbook with any hospital that we would align with. It meant that our metrics were all in. It also meant that anything that we did, including resource allocations, had to be done in a certain manner. It also allowed us to reduce our administrative costs. And so from looking back in terms of like resources, that's essentially how we moved forward as we thought about the growth of the organization. And we can talk a little bit more about what we did in terms of HRO, but that was the starting point for us in terms of the things that.
That's great, Fritz, thank you. And for those who are less close to kind of the nuances of how Medicare works with hospitals, that one provider number, that is uncommon.
Yes.
What that actually means is one hospital, 2 locations, or one hospital, 3 locations. Exactly. It is, technically the same hospital, counts with all the same quality metrics.
That's right.
All the quality there counts for your US News ranking. All in, 100% in.
All in. Exactly.
Which is really impressive. Yeah. Susan, maybe switching gears a little bit, Providence Clinical Network, huge ambulatory network, probably one of the largest of any health system in the country, multiple geographies. You've faced your own transformation journey at Providence related to the Providence Clinical Network, but also the system more broadly. Maybe same question for you. Walk us through kind of the motivation for change and then what you've been focused on, what you've been learning.
Yeah, and I'll frame it first from the lens of Providence. So Providence is a very old institution. We were founded by the Sisters of Providence and the Sisters of St. Joseph over 170 years ago. And so you would think, okay, well, that heritage and legacy seems very old and traditional. But in fact, our founding sisters were really their modern day entrepreneurs. They came, they set up health systems, they went into communities, they raised money and funds as well for minors. So really it's in our culture and our blood to transform, and you'll see kind of in the pattern of investments and innovations that we've tried to stay ahead of the game in terms of predicting where are the winds blowing and where do we have to invest and grow. When we think about transformation with the clinical network, we realize that it's care model transformation, but also economic payment transformation too. And you need really both in alignment. Our clinical network indeed is one of the largest in the countries. So when we think about our fully employed physicians, we have over 10,000 who are fully aligned through our medical groups. And within our ecosystem that provide care in our various facilities, over 30,000. And our clinical network has kind of what you would think of as traditional ambulatory assets like primary care, specialty clinics, but also retail clinics like express cares, urgent cares, virtual first, virtual care, and then hybrid models too, ambulatory surgical centers and ambulatory imaging centers. And so as we think about these care models, the patient really is at the center of all of those different care models. How can we really ensure that it's patient focused, that we navigate our patients through our integrated healthcare system as well? We know that it's not easy to be a patient. And by stitching together all these different pieces of the continuum, we have that integrated delivery network that can be patient friendly. So really those are kind of the different approaches that we've taken. We can always speak later about some of the really neat investments we've done in digital health, population health, and also in research and genomics.
That's great, thanks Susan. Ron, turning to you, same question, a lot of change going on at Mass General Brigham, a lot of care delivery transformation. What was the case for the change and how are you approaching it?
Well, thanks, Niyum. It's interesting listening to Susan's comments about how transformation and sort of reinvention was built into their fabric because it really wasn't built into ours. We also had a very long tradition, one academic medical center over 100 years old, the other 200 years old, and both had been amazingly innovative in terms of science and advancement of care and treatment, but not necessarily as innovative in terms of care models and not as used to collaborating with another major partner. So when Brigham and Women's Hospital and Massachusetts General Hospital came together in 1994 to form what was then Partners Healthcare, now Mass General Brigham. The plan, I think, ultimately was to create an integrated delivery system, but there was almost not a single step taken toward executing that plan. Initially, what was done was really combining the back office functions. Finance, for example, hate to call you a back office function, but...
That's fine. Nobody comes to the hospital to see me.
So finance, revenue cycle, IT, HR, those sorts of things were put together into really a super MSO. And the hospitals just continued to operate, and not only continued to operate, but operated very successfully. And as we added specialty hospitals, Mass Eye and Ear, Spalding, McLean, so we had expertise in, obviously, in eye and ear, in psychiatry and rehabilitation medicine. We had these two big academic medical centers, both of which were research powerhouses. We had community hospitals, we had a physician network, and they all operated separately. And the real compelling need for change for us came out of a whole series of things. Part of it was learning. Part of it was learning through the pandemic, how much we can do when we work together. Part of it was environmental and financial, where the post-pandemic pressures really leaned on us to think differently about how we'd operate. But I like the way Susan put it. The really driving, compelling reason was the patient. If you think about a patient who has a complex problem, say heart disease, and the very first thing we, as then, say, Partners Healthcare, when from 1994 to 2018, now Mass General Brigham, the very first thing we'd ask that patient to do is say, well, do you want to go to Mass General or do you want to go to the Brigham? I'd say, well, can't I just come to you and can't you just help me go where I should go? There must be experts in both places. We sometimes ran competing billboards in Logan Airport, which many of you traveled through to get here, and you'd walk by one and it would say, Best Women's Heart Disease Center in the World, Mass General, Brigham and Women's Hospital. You get the next one and it would say, Women's Heart Disease, Best in the World, MGH. And we were partners by that time, but not collaborators. So the big impetus over the last 3 years has been to put this together, to become one thing for our patients, so that our patients can look to us with trust, and we will navigate them to the right part of our system for the care they need, whether it's ultra high-end complex care or simple primary or secondary care. We will work with them. And we're not as far along that journey as we want to be, but that's the journey we're on. And I think our ability to put ourselves in front of patients as one thing is going to be truly transformative in a way that nothing else we've done has been.
I want to pick up on that idea of one thing, because you've highlighted what it's meant for Mass General and the Brigham, and also for the community hospitals and specialty hospitals at Mass General Brigham. Fritz, you became one thing, right, as with NYU Langone Brooklyn. How have you thought about kind of the cultural impact for the faculty, for the physicians, of saying, no, we are one thing? Was there identity that had to be challenged? How did you go about that?
So it's a really great question, and of course there were challenges because as we grew, and I mentioned what we were doing with the ambulatory network. Here we went from maybe less than 25 sites to over 300. And over 90% of the physicians were became employed. And as we grew, the question then became like, well, what is that thing? What is it that we're working towards? And what was very clear from the very beginning is that we were going to go after excellence in terms of the care, and that it was going to be patient-centered, and that if we did so in terms of quality and safety, we could all agree on that aspect. And so every element, and to use an example where we saw that there were variances, we would engage the physicians around what is it that we can agree on that would become a playbook that would deliver on excellence. The example that I can give you, and I was very involved in this, and it wasn't easy, was heart failure. If you saw 10 cardiologists, you probably found 10 ways of treating heart failure in terms of different medications, et cetera. Getting to the point where we had one way, like literally a pathway, to manage a patient with heart failure who might come to the emergency department and then be admitted and then be thinking about the continuum of care when they get discharged was defining for us. because it became our thing. This is the way we do things at NYU. You apply that then to a number of different conditions, and all of a sudden it grows. And what I'm telling you, by the way, over a course of 10 years, we went from saying, hey, let's just get everybody in a room to agree on heart failure. I'm proud to say to you that as of last year, we built that into what we now call NYU Heart, which is the equivalent of what you might call like an institute, et cetera, but it goes across our entire system, where we've grown to 5 hospitals, over 300 ambulatory networks. And if you say that one, everybody knows what it means. Everybody knows what should be delivered. And by the way, you should ask me, you say, well, then how do you know? How do you know that this is working? Well, the other thing that I should share with you is that we decided that we were going to measure everything. Because we implemented that EHR that I made reference to, built dashboards. We now have over 800 dashboards. I can tell you if that heart failure patient came into the ED, how long it took to get a certain dose of Lasix. Not if they got furosemide, how long it took them to get that medication and everything else thereafter. So essentially we could develop these report cards for the physicians. Everybody can look at this. It allows for accountability. That was really the foundational element of our one thing.
Yeah, that's wonderful. And it really makes it come to life, including that last part, right? You using the technology to kind of instantiate that workflow into what's happening. Susan, you mentioned technology a little bit in your first answer. As we think about care delivery transformation today versus if we were trying to do this 20 years ago, obviously technology makes certain things easier, might make certain things harder. What's been your experience at Providence Clinical Network and Providence more broadly in terms of using technology to drive care delivery transformation?
Yeah, absolutely. So I think the technology of yesterday in healthcare was kind of this layer that you applied, or maybe it was a vendor relationship, or maybe it was kind of static insights of what's going on, or snapshots. But I think the technology of healthcare of the future is predictive, it's precise, it gives you points of view across your populations, but also down to the level of the individual person too. And that integration piece is so important. So we've invested in a digital innovation group that really has developed strong core capabilities in AI. And alongside of that, also partnerships with companies like Microsoft too, that can also provide additional capabilities as we think about technology. But the important thing is that, one, it has to address an important business problem, something that really affects people on the ground. And so to be able to really crystallize what those problems are, you have to go out and talk to people and really understand, okay, what is it? What are those big boulders that you're facing? Or what are those pebbles in your shoe? So I'll give you one example, which is a product called MedPearl. And this was an idea that one of our Providence physicians had. And what MedPearl is it's a product, it's a clinical decision support tool. It sits at point of care. It's integrated into Epic as well. And what it takes is information, evidence-based practices. There's 700 clinically vetted pathways, care pathways, and we have an AI engine that then makes it very easy with a user interface that at the point of care, a doctor can really access what is the next best action. So if you're trying to figure out the right dose or the right lab test or radiology exam, you have that tool right at your fingertips. And so that's a platform approach where we've got the 700, but that can also change, right? So we can always load more care pathways, and as science changes and we know that the evidence changes, we can also enhance that too. So that's an example of something that was ideated by a physician, built by a physician for physicians too. And we have so many of those different types of tools, whether it's for inbox management or whether it's a chatbot for patients to access, that are really built listening to the people within the organization, and if it's a consumer-facing product, then to our consumers.
The point that you made there about built by a physician for physicians, addressing physician pain points, I think is really critical. It's so easy in the work that we do as large healthcare organizations to get very distant from care very quickly, and being able to tie into what do the clinicians actually need on the ground. And I think helps with the case for change, right? Sure. Also, as we think about doing things differently, getting that insight, bottom up. Ron, I wanted to kind of pick up on that theme with you. I imagine that with this big integration going on between Mass General and the Brigham, just a short little memo went out from from you and a couple of other leaders, and everybody said, yeah, perfect, right? We're all in 100%. All physicians said, yeah, lead us ahead, right? So how have you thought, given that that wasn't the case, how have you thought about building the case for change, communicating with physicians? If we're one thing for patients, you know, how do we make that resonate more deeply with the faculty and the physicians?
Yeah, it's really interesting question, Niyum, and I wish I had the answer. It's been really difficult working with our physicians. At the intellectual and inspirational level, they totally get it. And some people were really, many people were really impatient with us. Why didn't we do this a long time ago? But we had to take some deliberate steps to move us sort of stepwise ahead. We had to really take a leap. We had to get onto a whole different curve. So on March 13th, we had all of our chairs together, and we told these world leaders in their disciplines that we were only going to have one department in each discipline between the Brigham and MGH with one leader. And we were talking, of course, to 2 departments with 2 leaders at the time in most of the departments. And it was really inspirational and amazing how our leaders responded to that, because your first instinct, of course, would be, oh my God, like what's going to happen to me? But they moved past that so quickly, and by quickly, I don't mean in a few weeks, I mean in a few minutes or a few hours. And some of our chairs wrote emails out to their faculty in the few hours after that first big meeting where they really learned what our future was going to look like, and wrote these amazing things. Our chairs of neurology got together and wrote to their faculties together, talking about what promise the future held. The chair of medicine at MGH wrote about the brilliant future that lay ahead by combining forces with the 2 of the best departments of medicine in the world getting together to solve problems together, and how that was the way of the future. It was really amazing. There is, however, a lot of pick and shovel and door-by-door, door-to-door work to be done. And it's often been said, if you want people to really start to assimilate a message, you need to make sure they hear it at least 5 times. And it turns out that's not true. They need to hear it 25 times. And having them hear it from trusted sources over and over again, particularly with high consistency, high fidelity to the message that's coming from some sources they might consider less trustworthy, is so important. And I think in the early stages we did a lot of institute work as well, in the early stages of the institute work, in the early stages of integrating the departments, we did not pay enough attention to making sure that the individual physicians at the division level and the section level and just individual faculty members had a chance to be heard, had a chance to hear it themselves, and had a chance to ask questions. And we've done a lot of work around that since. But Niyum, tongue-in-cheek, said, I guess an email went out, and I think it comes back to that old thing of, never email when you can call, never call when you can meet in person, and never meet in person when there's no point in talking about it at all. So I think as we work through with people, that personal touch that has to be multiplied through rootlets and things to get to the thousands of faculty members we have. We have over 85,000 employees. Getting that message to all of those people requires all of our leaders to really lean in, and we're still working on that.
Fritz and Susan, any insights that you have, thoughts on this kind of communication piece of it, the making things resonate at the point of care as you think about transformation? Because I see we're all wearing suits here. We don't want to be and I'm not even a doctor, but we don't want to be the suits sitting in corporate offices saying, oh, we must transform clinically. How do you, any learnings?
Yeah, so a few. One, I think getting to the people's why is pretty important. So we know that people join Providence because the mission really means something to them. A lot of times that's why they're here. And so that thread somehow needs to make sense, needs to be coherent with the need for transformation as well. So we're able to kind of pull on our history and legacy, and that actually is quite meaningful. And then at the same time, having the right representation. So like what Dr. Walls was saying, right? You need people who can really deliver that consistent message. And it's also the education. I think we find ourselves in a very, very difficult time today. And not everyone understands why. Not everyone understands what's going on in the outside world of healthcare, right? So kind of bringing those viewpoints and education to people, I think is really critical so that they can really understand what sometimes are very difficult business decisions, sometimes what can seem to be in a land of gray in ethics as well. And then having really good processes. So we have a process called discernment by which really difficult decisions are made, which brings in multiple stakeholders too. So I think if people have trust in the process, that when really tough decisions are made, that there was a rigorous kind of process, which is tried and true, they can feel a little bit more confident. And then lastly, building your community of ambassadors, of champions, that army out there that's going to help deliver the message. And when we're really large, we're over 7 states, we've got 52 hospitals and 1,000 clinics, you can't reach everyone, right? You can maybe send an email out, but you really have to think about those ambassadors and those layers. And it's not just about spreading it top down, but then creating the opportunity for that bi-directional feedback in the governance structures so that you can really leverage that group of leaders as well in the communication.
And I love what Susan mentioned about the, not only framing the why, but also developing trust. So let me share with all of you a moment for us that really catapulted our ability to articulate the why and get everybody to understand the why and then build trust. And some of you might know this story, but many of you might not. But what happened with us actually was that when Superstorm Sandy hit, all our facilities were closed. And for the first time ever in history, if you go from 23rd Street in Manhattan and First Avenue to 33rd, there are 3 hospitals: a VA hospital, a public hospital, Bellevue, and there's us on 30th. All 3 were closed. We serve all 3 in terms of our faculty, and and as a physician, I'm a gastroenterologist. I can tell you, actually, I was going through all 3. And in less than an hour, done. Everything is shut down. So what you had, literally, were people saying, well, what do we do? Where are we going to see patients? How are we going to teach our students? And where are we going to do research? Because all the facilities were closed. So this was probably the most important decision that was made by our dean and CEO at the time, Bob Grossman, and the board. Said, okay, we have 0 revenue. Guess what we're going to do? We're going to continue to pay everybody. We're going to continue to pay everybody even though we have no revenue. Imagine what that does to build the trust and saying, okay, now you don't have to worry about paying your bills. We're going to come together tomorrow and we're going to start working on the plan of how do we rebuild. And we're going to get better because our patients deserve no less. So that story wrote itself in terms of the why, because this is what we're going to do. Fast forward, there are bigger challenges once we got back on our feet, and there are things that we have done that it was easier to articulate the why because there was that trust. Case in point, some of you might have read that we decided that there were 2 things that happened. One is that when we were doing the full asset merger with Brooklyn, it would have been easy for people to say, why? Why would you take on a community hospital with the highest rate of Medicaid and Medicare in the country, Sunset Park, Brooklyn, true story. Why? Why do it? Well, the reason was because what we saw was that 50% of the patients that we had were going from that borough in Brooklyn to Manhattan and going back. We said, well, why couldn't we do something different and serve the community and invest in it and deliver that care in a different way? So our staff and our physicians, everybody said, oh, okay, we get it. Then there were the more complex things. So why would you decide to do one of the most complicated face transplants and transplant a globe, an eye, for a veteran? 143 individuals, physicians, staff basically said, okay, we get it. We trust that not only will that help one patient, but what it actually did is advance science. It advanced education. Because believe it or not, we were still actually doing these studies where all of a sudden things that people didn't think were possible, that you would revascularize that globe and get signals like, oh my God. And so our journey to that transformation is that we really invested in the people at a time when we didn't have a home, we didn't have a physical structure. We supported them, and then they were able to support us in our strategies in terms of what it is that we're able to do now.
That's great. Thank you, Fritz. Susan, earlier on you mentioned working with, sometimes doing things yourself, sometimes working with partners. If we want to really change for the future, there's a, and in this audience we probably have biopharma execs, we have VC leaders, we have med device leaders, we have people from health plans, care delivery, big tech. As you think about, and I'm going to ask, Ron and Fritz, I'll ask for your thoughts on this as well, but, Susan, maybe starting with you, as you think about when you are working with partners, what do you look for in a partner in order to make sure that you can align how you're focused on tackling a problem? And maybe also what advice would you have for organizations that want to partner with health systems?
Yeah, that's a fantastic question. And we are really quite flexible and open to thinking about partnerships. In fact, we have a number of partnerships with large companies and also startups, whether it's Gallery for multi-cancer early detection, or with Microsoft, or with pharma. And so we really think about what are the internal capabilities of Providence, and then what are the capabilities of the partner. And when coming together, really what is the outcome that we can achieve too, right? So there are certain things that we do very, very well, and there are certain things that others will be doing much better. And really finding those intersection points is important. We talk about finding like-minded and like-hearted partners, and so that is important to us, right? So it still has to make sense in terms of the broader picture of what our mission, vision, and values of Providence is, and being able to really service our patients and our communities and really further our mission. I'll take the example of maybe kind of like tech and research also. So, one of the benefits of Providence is that it is really quite large. And we have a Providence Research Institute and a Providence Research Network. And sometimes folks might not think of Providence as doing a lot of research, and yet last year alone we did over 2,400 trials and had over 1,600 publications and presentations. So there are things that we can really think about leveraging, the kind of scale of Providence, the geographic spread as well, the ability to reach all different types of patients. And if we can kind of merge that with partners who can build, come with a specific skill set, we can really think about what we can drive in the new way of diagnostics and therapeutics, population health, or personalized medicine. So really it's kind of achieving what is that possibility. And when we're able to merge these different capabilities together, there's really that potential. So we have a robust partnership pipeline. We have platforms through our research institute, our elite clinical institutes, our genomics institute as well. So there's a way that you can kind of anchor in and integrate into Providence. So if anyone's interested, our Providence team is here. We'd be happy to chat.
Ron, what'd you add?
There's not much to add to that, actually. It was interesting for us. I think we went through a period, we were real innovators in the 90s, 80s and 90s actually, in digital health and digital health records. And we got out in front in a lot of areas. We had big research enterprise. And I think along the way, we kind of convinced ourselves that we were so smart that we didn't need anybody's help. And we liked to build it. We didn't like to buy it. We didn't like to partner on it. We really just liked to build it. And we went through quite a long period, I would say, like that probably was a really positive thing in the 90s, where we were out in front and became kind of neutral, and then probably started to hold us back. And we've really completely flipped our thinking in that now. Susan described it very well. What are your strengths? What are the strengths of the partner? We welcome partnerships now. We know there are people out there who are doing things, particularly in narrow spaces, that are doing them much better than we are. And we want to learn from them and partner with them, and we'll bring our strength and they'll bring their strength so we can work together. And we're working with Microsoft too on a co-innovation platform, but we're building an entire digital twin of our academic medical centers so that we can run simulations on the digital twin while the real ship just sails forward, as it always has. So we have a lot of really innovative work going on, but what we've really learned to do is to look for the expertise that matches what we need and look for the values that match what we have. So for example, some of the innovative primary care models that are really looking at just plucking an educated, employed, tech-savvy group of people with relatively good means. We don't really need that. What we need is ways of developing primary care and delivering it on a broader base to everyone, to those people, but also to people who are unemployed or maybe even undomiciled. So we have been able to find fantastic partners in areas that match up well, but as with, I'm sure, everyone on the stage, we're pretty selective, and we really want to stay focused on our mission as we develop and execute on these partnerships.
Anything you'd add, Fritz?
Yeah, I absolutely would agree that the importance of being very clear on what question are we trying to answer or what problem are we trying to solve. In addition, does it provide value? And to Ron's point in terms of thinking about this in terms of like, what is it that we're going to invest? What are we getting on the other end? And I'll say that, that we're very, very much interested actually in technology. We love it. Speaking personally as a gastroenterologist, I love playing with toys. I'll tell you that, we did some of the first studies actually with the pill cam, which now has had several iterations. But here's the interesting thing that I would add in thinking about and assessing a partnership or something. It has to be like, is this something that is facing the physician or the staff, or is it patient facing? And it turns out that when you consider whether it's patient facing, it's even more difficult, or we're even more selective. Why? Because there the questions that I often ask is it serving all the patients or all the communities? What do I mean by that? Something as simple as language. So if it's not in English, is not a first language for the individual, well, how does that work? Does it provide that opportunity? What about individuals with disabilities? So you can have a great platform, but it can't be accessed by all the patients in various ways. And so those questions become important as you consider, like, what is it that we're investing in that is patient-facing? And frankly, I'll fall on the sword and say that we have done that, where we've gone down a path, we've had a partnership. It was wonderful. Technology, I was so excited about this. Oh, this is great. And then we deploy it, and a patient asks, well, my mother speaks a different language, or my father. It's like, oh, we didn't consider. Now we have to go back and say, well, how many languages can we actually deploy this in? Or consider individuals who, honestly, actually are not as able to use technology, the elderly, for instance. And we have platforms in which we're trying to push things out to patients. You engage in this, you press this button, but they actually can't. So that's important for us, actually, in terms of these partnerships, to think about how else might we do this. It's value add, but we want to make sure that we're not leaving patients and communities behind.
That's great. One more question for each of you, just kind of buzzing through each of you, and then we'll take some questions from the audience as well. So, Bill Gates famously said we always overestimate the amount of change in 2 years and underestimate the amount of change in 10. So we're talking about transforming care here. And I'll start with you, Ron. If we're sitting here in the fall of 2034, 10 years from now, and I asked you the question, hey, what happened in the last year from a care delivery transformation standpoint anywhere in the country that you're most excited about? What do you think it would be? What do the next 10 years hold for us in terms of transformative care delivery change?
Thank you for preparing me for this question. I think in the era from 2000 to about 2018, maybe 2020, technology incurred a huge debt with our providers. It solved problems like standardizing the recording of certain elements necessary for certain billing functions and tracking patients longitudinally through the system. It solved elements like that, but it solved them by placing so much of that burden on the providers. And I think there's a huge debt there. And I'm hoping when we're sitting here in 10 years, and you say, what's the biggest thing that's happened in the last 10 years? I'll say that debt has been repaid with dividend. That technology has now advanced to the state where some of the things like Susan was describing earlier, where we're supporting providers, we're doing way beyond what ambient documentation can do. We're doing ambient documentation with differential diagnosis and treatment plans and catching things as people are thinking or entering them, that will get much more to easy forms of entry directly from the patient, less hands on the keyboard stuff, and that we'll be able to virtually connect with our patients almost universally and almost continuously. So I have absolutely no idea how any of that's going to happen. I know there are people in this room who probably do. But I think seeing the yield on that technology debt that we asked all our providers to pay, that would be a huge advance for our providers, but it'd be even more big advance for our patients.
That's great. Susan?
Three things, and these are my hopes and aspirations for in 10 years. Whether they'll happen, don't hold me to it.
Well, that's what everybody in the room is for,
That's
right?
right,
We all
that's
need
right,
to,
yeah.
this is the challenge. We need to achieve
Yes.
the three things that Susan's about
And I
to say.
do need the federal government represented here too. So I think the first one is I would love to see more alignment of our payment models with really the quintuple aim that we've been talking about this whole time, right? And that will then link up to the care model transformation. And for that to occur, I think we need CMS to really hold to their word that by 2030 that we are flipping payment models into these alternative payment models, which are value-based. So the reason I pointed out the federal government is that payment really drives a lot of the pace of transformation that we can achieve. So that is very important. Number two is I think the crisis with the workforce. So if you just project out by 2034, we simply don't have enough workforce, whether it's doctors, nurses, lab techs, rad techs, doesn't matter, really any segment of the workforce. So by 2030, my hopes and dreams would be that we do have that augmentation, we do have that assistance in certain places, that we do have the automation, which is really driven and empowered by things like AI and new technologies. With the caveat that we're not really looking after those technologies to create more burden, because we also know there's money to be had when people create actually more steps too. So we want to avoid that. And the third one, I think, is really the new wave of diagnostics and therapeutics. It's where population health meets personalized medicine. And already we're seeing a lot of advancements where we can bring those technologies and AI and digital tech to drug discovery, to clinical trials, and to really personalized medicine. We can really rethink how we treat swaths of people, swaths of populations. And that, in turn, can create a virtuous cycle with our economic payment models if we can really better pinpoint how to treat people earlier and better to keep them healthy. So those are kind of my three categories of wishes.
That's great.
That's really excellent points. And I will just add, just pick up on what Susan said about diagnostics and therapeutics. And for me, like if you look in the future, the speed at which we do things will change completely. And the so what here is that if you go back and you say there was a time in which patients would spend 2 weeks in the hospital, that doesn't happen anymore. And very rarely do you see patients spending even 10 days. You consider that basically an outlier. Well, that's going to dramatically change as we think about how quickly we will be able to diagnose and develop therapeutic plans. Because when you think about what is it that happens between the patient comes in, they get a biopsy or something, what are they waiting for? What's going on? Well, the whole process for labs is going to be completely different. I mean, it's going to be, whether you're talking about digital pathology, we already have digital radiology, but all that actually is going to be transformed, especially as you now add AI. On that note, the reality is AI will completely transform the workforce. No mistake about it. It also means that if that's true, we have to rethink how we design hospitals. We have to rethink how we design ambulatory networks, because it doesn't really make sense the way in which it happens right now, given all the tools that we are going to have. And when I say this, I am challenging my teams right now to start and think about how we round in the hospitals. It's the sed way that I rounded when I practice. Well, that can't be. And so we have to start rethinking these things so that years from now, when you walk through the hospital, you're going to see something completely different, even in terms of the infrastructure, the way individuals work, who's actually there, and what tools they're using in order for this actually to happen. And I think it's going, and I do agree that it's going to happen quicker than we probably think, but it's already starting.
Thank you. We have time for maybe one or two questions from the audience. Any questions I didn't ask that you want to ask? Yeah. Somebody's bringing a mic for you.
My name's Ted Technos, University Hospitals, Case Western. You brought up the alternative payment models. The goal for many of these is actually driving down costs, decreasing reimbursement, You know, how do we continue to achieve the academic mission in our academic medical centers when the margins are going to continue to get thinner and thinner and thinner with alternative payment models?
I'll start with this one. So I think, you know, when you actually look at fee for service and the amount that you're getting paid, the margin compression is actually getting worse and worse. And so we have, over our 7 states, certain markets that are very, very mature in these different payment models. And as we're able to accept more risk, we move closer to the premium dollar. So in California, we have kind of this construct where essentially we take a percentage of premium from the payers. We also have our own health plan, Providence Health Plan. So then we control the dollar and really are able to design the care models so that we can do all the things that are upstream but not reimbursed for on a per-click model. So I think it's actually potentially a way out of the margin compression that is happening from reimbursement.
That's great.